Okay, so the first debate is on the question of should Narcan be available as a take-home med for free for heroin addicts? And the first speaker is on the pro side.
Okay, so we're going to start off with the facts. Opioid abuse is a growing problem, partially due to the increase in prescribing. According to the CDC, there were 219 million prescriptions for opioids in 2011 compared to only 76 million in 1991. According to the World Health Organization, there's estimated to be 3 million people in Europe and the US that are addicted to some type of opiate. There were 4,000 deaths in 1999 and 16,000 deaths in 2010. So due to the growth of abuse, there's been a growth in death. And using take-home Narcan will help these patients stop these deaths from occurring. According to the FDA, it's the leading cause of injury death. And as I said, it's a death that's preventable and inexpensive. It's 98% effective at reducing death in overdoses, and there are no serious side effects from Narcan. And not only does it help stop the death, it also will shorten the time that the patient is in this overdose. And during these overdose occurrences, the victims experience oxygen deprivation, which just a few minutes after hypoxia to the brain injury does begin to occur. According to a survey done by the Journal of Urban Health, most overdoses are with peers, and most deaths occur within 1 to 3 hours of overdoses. So using the Narcan right away will save these patients. Also, according to the survey, only 51% of drug abusers reported soliciting assistance from 911 due to their fear of the repercussions of what the police might do to them. So obviously, a take-home Narcan will help in these cases because it will save them, hopefully even without the help of 911. Also, according to the survey, 87% were in favor of the program for take-home Naloxone. So we know that these programs will be helpful. So Georgetta is going to talk about the programs that already exist.
I'm going to talk about the community-based opioid overdose prevention programs providing naloxone. In 1996, community-based programs began offering naloxone and other opioid overdose prevention services to people who use drugs, their families and friends, and service providers, for example, healthcare providers, homeless shelters, and substance abuse treatment programs. These services include education regarding overdose risk factors, recognition of signs of opioid overdose, appropriate responses to an overdose, and administration of naloxone. The programs reported training and distribution of naloxone to 53,000 people and receiving reports of 10,000 overdose reversals. Providing opioid overdose education and naloxone to people who use drugs and to people who might be present at the opioid overdose can help reduce opioid overdose mortality, which is a rapidly growing public health concern. 19 of the 25 states with 2008 drug overdose death rates higher than the median, and 9 of the 13 states in the highest quartile did not have a community-based opioid overdose prevention program that distributed naloxone. Nearly half of the opioid overdose programs reported problems obtaining naloxone related to cost and the supply chain. Price increases of some formulations of naloxone appear to restrict current program activities and the possibility of new programs. Economic pressure on state and local budgets could decrease funding and opioid overdose prevention activities. Naloxone availability can reduce opioid overdose mortality.
I think in addition to these programs help stopping death, it also may help patients get closer to their health providers so that they are more likely to stop abusing their drugs. And I feel that as we've learned through all semester, drug abuse is a disease, and these patients should have the opportunity to prevent death from their addiction.
Thank you very much. Now, for the con side.
everybody. I'm Peter. Okay, so the first thing is when you start talking about naloxone, so you may have heard recently the FDA approved Avizio, which is the naloxone auto-injector. If you look at the package insert with any naloxone, the main thing you need to realize is it's not a substitute for immediate medical care. And the person administering this, they need to call 911 right away. The reason for this is naloxone only has a half-life of 30 to 120 minutes. This depends. If it's IV, it's shorter, close to half an hour. IM, it could be up to 2 hours. But many opiates last a lot longer. The debate we're talking about here is Narcan for heroin addicts. So the main metabolite of heroin is morphine. This has a half-life of 2 to 3 hours. Naloxone is only 2 hours. So the drug is not lasting long enough, and this person can relapse back into the overdose. So they need to seek medical attention. Another thing is if you give these people naloxone, the pro side claims that there's no side effects, but actually this can do a lot of harm. So a lot of these patients, they're not just doing heroin, they're doing a lot of other medications as well. So this can not only precipitate opiate withdrawal, so some of these symptoms are related to catecholamine excess. So this can lead to tachycardia, arrhythmias, seizures. So there's actually a couple of mechanisms they suspect for the seizures. It can lower the threshold, it can unmask other drugs. So for example, if the person's doing heroin and cocaine, then suddenly the heroin is gone and they can relapse into a seizure. Or it can also, because of the tachycardia, they can become hypoxic, or they can have a hypercarbia, which is very high CO2 levels, leading to seizures. So it's not a safe medication. It needs to be medically supervised. And then the other thing is there's already all these barriers to calling 911 and emergency medical services in current addicts. So in Scotland, where they have some of these programs, they did focus groups on current and past addicts. And there's a lot of very big barriers to calling 911 already, or 999 as they call it in Scotland for their emergency medical services. So some of them include legal. So these people are already afraid of being arrested. There's practical barriers. So for example, if they're living in an apartment and they have a no drug policy, these people can be evicted. If there's children present, then social services may take these children away. They might not have a phone. Maybe the person is on probation, and then they're afraid that calling the police will get them back into jail. Sometimes if it's a dealer in a victim situation, maybe they're being robbed. There's a lot of social stigma. For example, do you want your neighbors knowing, seeing an ambulance showing up? There's peer pressure. Your friend, they don't want to lose this high. They might think that, oh, they were okay, and you could actually lose a friend this way because they're angry that you called the police. And then actually, if somebody does overdose, there's been reported cases of repercussions and retaliation from the family. So, the victim's parents or friends or something may retaliate against you for calling the police. So there's already all these barriers. So if you give these people naloxone, they're going to be even less likely to call emergency medical services. And as I already mentioned, it's very important that these people get follow-up care. And Stuart's going to talk about another big point.
My big point is the cost of this. As we mentioned earlier, the FDA approved Avizio, and it's likely to cost upwards of $200 a dose. So if you need to give more than one dose for one episode, that's $400 just to reverse an overdose. And if we're going to be providing these for free, that's a lot of money we'd be spending. And in addition to that, you need to be able to reach sort of a critical mass of users just to be able to get a discernible difference in the mortality. So if you're only reaching 25% of the users, it might not do much to reduce mortality in the end, if you're looking at it from a population-based perspective. So as mentioned before, the families and friends and bystanders who are around these users will also need training on how to administer the naloxone, so that's another time and cost issue, and reaching out to all the people around those users. And also the 911 emergency call handlers need to be trained in how to instruct people on how to administer the take-home naloxone. In addition, the naloxone has a 2 to 3 year shelf life, so every 2 to 3 years these users will have to change out their medications if they haven't used them yet. So that's another sunk cost with that. So we did a bit of data out there, and we found out that for every overdose death, there are 825 users. So if you were to treat that population, you would have to target those 825 users. And so for a city of Detroit, approximately 700,000 people, has an incidence death rate of 12.2 deaths per 100,000 population, which comes out to be about 86 overdose deaths of users in Detroit yearly. So if you're targeting those people, that's about 70,000 users in Detroit that you would have to target. And that comes out to be close to $1.5 million to $15 million, depending upon the cost of the naloxone alone, just to be able to treat those patients and to be able to get naloxone to every single one of those people. So basically, that money could be better spent on other things, such as expanded access to existing opioid treatment programs, and with the way budgets are these days, is that funding really available to use for this program? It would probably be better spent in other disease states that your money offers a better return at. So
to wrap it up, so I mean, there's three major points. I mean, it's a very good idea, but it's not very feasible. So I mean, first of all, it's not a solution. It's only a temporary, saving measure until these people get to the hospital. But as we discussed, there's all these barriers on why these people are already not going to the hospital, and this is only going to make it even worse. And then there's the cost. So the pro side, they want to give free naloxone to all these addicts and homeless people and everything. And it's a very, very large cost, and it's not something that's very financially feasible. And as Stuart said, the money could be better spent. Thank you.
Thank you very much. I think we'll take a brief break. We're back for the rebuttal, and again, we'll start with the ladies on the pro side, and 5 minutes, and then we'll go to the con side.
Okay, so first of all, you guys mentioned that the patients are scared of the repercussions of calling 911, and even after they inject it, they'd be less likely to call 911. But in these programs, I feel we can educate these patients in the fact that they won't have any repercussions for calling 911. I think just getting the word out and educating the patients is the main issue, and these programs will allow us to do that. Not only that, but we also can train the patients on how to use the Narcan. You also mentioned that was a problem. Ultimately, it's going to be saving lives. And also, you guys said that we wouldn't be able to reach enough people, but as we said earlier, it's saved 10,000 lives already, and I feel like more and more lives will be saved throughout it. And also, as I mentioned earlier, 87% of users would use the program, so obviously it will be used.
And then you mentioned about the Evizio, the handheld auto-injector. It is injected into the muscle and under the skin, and in one pharmacokinetic study of 30 patients, a single Evizio injection provided equivalent naloxone compared to a single dose of naloxone injection using a standard syringe. And after the device is turned on, it provides verbal instruction to the user describing how to deliver the medication, similar to automated defibrillator, so it's easier to use than the regular injection. And regarding the deaths and the money that should be spent on other diseases than on opioid abuse, in 2013, the CDC and prevention reported the number of drug overdose deaths has steadily increased for more than a decade, and the drug overdose deaths, driven largely by prescription drug overdose deaths, are now the leading cause of injury death in the United States, surpassing motor vehicle crashes. So opioid abuse is a big problem, and we should address it.
Thank you. Now the con side.
Okay. So I'll start us off. So these programs educate the users, but the problem is it's not just the user that needs to be trained, but it's their friends, their family, their siblings. So yeah, maybe a lot of their friends are also heroin users and they know how to inject these naloxone, intramuscularly. But what if it's your mother? What if it's, your grandmother? You're at her house, you're in her basement. Are these people going to know how to use these medications? And there still are repercussions. As I was talking about, what if there's children in the house? Social work will still get called. Police will still come. These people are on probation. They have criminal records. These are all still issues, and there are repercussions for calling 911. So this take-home Narcan program, it will not solve that, and the fear will still always be there. And then I was interviewing a friend who's a paramedic in Oakland County last weekend, and a lot of these patients, when they go to the hospital, it's a life-changing event for them. This is when they finally get into the system, into healthcare. They finally start getting help. They realize what kind of road they're leading themselves to. And if you give these people take-home naloxone, they won't have that experience, and they will just continue to use.
In their initial talk, they mentioned about that there were really no side effects with administration of naloxone. That's not necessarily true because of concomitant drugs and other disease states that they might have, as we mentioned earlier, and also that in terms of, as Peter mentioned, these patients would be less likely to use emergency services after using naloxone. Even more so than before, because of those repercussions of social services getting involved and getting involved with the courts in terms of having to go to required treatment programs and stuff like that. And that's important for these people. If you have addicts who are even less likely to use those services, you're going to end up with less recovering addicts and therefore more use of the naloxone. And it's going to be a feedback mechanism that makes it more and more expensive because you're having to treat these people with the free naloxone all the time. Especially if you're using a VZO, even though it's easier, it still costs quite a lot of money. Especially even the training of the users, because you have to contact them, contact all the peers around them, and that's expensive, and you have to be able to train all of them, which is also expensive in terms of labor. There's a little bit of a social stigma with contacting peers around you if you're a user, especially if they don't know that you're using it. So if your parents are anti-drug and you go into their house and you have a drug overdose, they would need to know that you're a user and know how to administer the naloxone. But what's the likelihood you're going to tell your parents that you're using? And they also made a assertion that that these naloxone treatment programs will bring the patients closer to their providers, and that's patently untrue because they're much less likely to use those services and be near those providers when they're treating their overdoses on their own as compared to when they use the services provided by the healthcare services. And as we mentioned before, if they don't use those services, they don't get all the other treatment requirements in terms of getting social services and courts involved.
So to wrap things up, I wanted to take-home thing is this debate was about take-home Narcan for free to heroin addicts. So we're not just talking about opiates in general, we're talking about heroin specifically, and then providing it for free to these addicts. So there's a huge cost involved to this for a very small subpopulation. So the medication may be very good, but there's better ways to spend this money, and the take-home point is you have to remember that so that it may save lives, but
it's not worth doing.
There's better ways of spending this money and getting these people to get the actual medical help that they need. Thank you.
Thank you very much.
That was a terrible